Hi there, and welcome to the AMH webinar. I'm Dr. Perry Jansen. I'm a physician with African Mission Healthcare. I'm here in my second home country here in Malawi, where I served as a physician for 16 years and had the privilege of starting an organization called Partners in Hope, which has grown from a smallish HIV focused project now to working towards being a full hospital. And we handed over leadership of Partners in Hope about 10 years ago. It was my dream as we started 20 years ago, this project, to hand this over to Malawian leadership and have it be truly a Malawian owned and Malawi vision to run a hospital that was really a center of excellence for the capital city of Lilongwe. So I am very privileged to be able to be here to basically talk about our laureate for the Gerson L'Chaim Prize for this year. This is a prize that we give annually. This is the ninth award, I believe, that we've given. It's a $500,000 award that goes for excellence in Christian healthcare service. This is the third time that this has been won by a female African leader. And so we're particularly proud of that. And I'm proud that it's here at Partners in Hope, where I consider home. And I'm here with Dr. Agnes Moses, who is the laureate for this year. If we can expand out to the three of us. Dr. Agnes Moses is a brilliant internal medicine doctor and was a researcher when we snagged her away to be the executive director at Partners in Hope. She took a cut in pay to come and lead this Christian organization, and she felt really her calling to do that. We're also joined by Dr. Bill Maronia, who actually joined after I had left when we started doing surgery here at Partners in Hope. Actually, the African Mission Healthcare with resources from Mark Gerson enabled us to be able to open an operating theater, hire a surgeon, and now he's been doing surgery for the last 3.5, 4 years, 5 years. Has gone by fast. And we're excited because the focus of the L'Chaim Prize will really be to grow the capacity of surgery and then maternal and neonatal care at Partners in Hope. So we're also excited to be joined by Mark Gerson, who's the benefactor of the Gerson L'Chaim Prize. He is our co-founder at AMH and one of our biggest fans and biggest supporters. And he and his wife, Rabbi Erica Gerson, are the ones that came up with this idea of the award. That's one of the largest awards, I think the largest award for this type of service, for Christian missionary service. And so I want to invite Mark just to take over from here. I think he has some questions that he wanted to ask our panelists. And also those who are listening, joining us online, we hope to have some time at the end for you to ask some questions. So if you just click on the question and answer at the bottom of the Zoom screen, you can submit questions, and at the end, we'll try and answer as many of those as we can. So Mark, I'll turn this over to you.
Okay, Perry, thank you. And Agnes and Bill, it's such an honor to be here with you today, and congratulations on winning the prize. And I mean, just blown away by what you're going to do with this $500,000. And just putting that in context, I got the numbers on the hospital budget, which are astonishing. So the annual budget of the hospital is $2.3 million. Admissions, 1,500 admissions a year, 58,500 outpatient visits a year. That's 36,500 in the private clinic, 22,000 in the free HIV clinic, 695 surgeries a year, 6,000 free HIV patients, which generates 22,000 visits. You provide 20% of Malawi's HIV lab services. You mentor 130 clinics and hospitals in HIV care, 30 inpatient beds, 3 ICU beds. In the high dependency unit, 4 beds, operating room 1, and you serve a population of 2.6 million people. And all that on a budget of $2.3 million, which is a few surgeries here in New York City. So how do you do this astonishing amount of patient care with $2.3 million.
Thank you, our audience on the webinar. Thank you, Mark and the AMH team. For us, as Perry was giving the introduction, we've got a free service which caters actually about 50% of our patients come for free service and 50% are fee paying. So we try to be as equitable as possible. We never take somebody away because they don't have money, but our aim really is to provide quality, equitable, and sustainable care. So everyone that walks through the door, for the HIV clinic, it's free, partly sponsored through our external grants with what used to be called USAID, now State Department. Partly some of the services, very few, subsidized through Christian Health Association of Malawi. And for the fee-paying patients, most of this is on a local medical scheme. So for the patients who are unable to pay, there is also a small fund which we raise locally. It's called Hand of Hope. We cater for even just basic services, but that's how the services are described as equitable. We try to limit ourselves to do what is doable within the budget. For the 2.3, let me just clarify, the 2.3 million in the catchment area, that's the area within the district of Lilongwe. And the 130 clinics, I would say usually it's 123 we are supporting through the HIV program, including the one which is ourselves. That's scattered throughout nationwide in Malawi against a population of about 22 million Malawi. So we support basically about 20% of the HIV population in Malawi using these external grants. So that's in short how our operations are. Thank you.
Amazing. So in addition to the HIV services, you're doing 695 surgeries a year, and we'll talk about how that's going to be expanded. But what kinds of surgeries are those?
Thank you, Mark, and thank you everyone who has joined us this evening. So I do mostly general surgical procedures, and as a general surgeon, I do almost all abdominal surgeries, from bowel resections, anastomosis, cholecystectomies, removal of gallbladders, to doing thyroid surgeries. I do lots of breast surgeries for breast cancers. So that's, in a nutshell, some of the procedures that are covered there. I do basic orthopedic procedures that I can manage, but these mainly amputations and the like. But that's the main orthopedic procedure I would say that I do. But most of those are general surgical procedures, abdominal procedures.
So what a wide variety of different kinds of surgeries. Now let's talk about the $500,000 L'Chaim Prize, which you've been awarded. What's going to improve and change as a result of the $500,000?
So for surgery, that is going to have a very huge and enormous impact on our surgical capacity. At the moment, we only have one operating theater. And as Dr. Perry has introduced initially, I'm the only surgeon who has been operating here at Partners in Hope for the past 6 years. So I do all elective procedures alone. I do all emergency procedures. And I also have an administrative role that I do. I am the current medical director. So that's a lot of work on me. So this prize is going to help us to increase the number of operating rooms. Currently, as I've already said, we only have one. And we'll be able to get a second pair of hands from a second surgeon that we will be able to employ using this prize money.
One of the things I'm excited about with this grant is right away in the grant, probably in the next couple of months, we'll be purchasing equipment to do what's called laparoscopic surgery.
Yes.
Here they often call it keyhole surgery. It's and I think it's people who get their gallbladder in the States, out in the States, this is the only way they do it, basically. They use a little scope and special instruments that can take out the gallbladder or do the surgery that they're going to do with only very small scars, and enables people to go home sometimes the same day or within a day or two, rather than having a big scar that takes, several days in the hospital and weeks to recover. So there are a handful of places in Malawi that you can have that done. And we want Partners in Hope to be the place that they can go get that done, because it's really something that makes the surgery safer, makes it the recovery much easier.
So Perry, is the some of the L'Chaim Prize money is going to purchase the equipment to enable the
Yes.
laparoscopic surgery?
That'll be some of the first things that we do. We'll be hiring a second surgeon and purchasing the equipment.
And equipping putting that equipment in the theater.
Right, exactly. Yeah.
So is that equipment going to help enable more surgeries because people will be able to leave the hospital sooner?
Yes, that is correct. It will enable more surgeries, as well as we will be able to do more surgeries, as most people will not be admitted in the hospital for a long time. So we'll have a high turnover of patients as well, who will be coming in admitted in the hospital. To add on that, laparoscopic surgeries, usually they are shorter when you are used to doing them. As Perry was describing, you can do a laparoscopic cholecystectomy for less than 30 minutes. And you can do laparoscopic appendectomy for 30 minutes as well. But for open surgeries, it takes a longer time to do the same kind of surgery. And the recovery period for the patient is also longer. So all these will be reduced by the use of the laparoscopic equipment that this price will use this price to purchase.
Okay, question from a pre-med student. How much does that equipment cost?
There's local suppliers, the prices. Yeah.
So we have local suppliers, and we'll be able to get the equipment at around $65,000.
Okay, so $65,000 is going to enable that many more surgeries. Now, do you have the you referenced an additional surgeon? Is that person identified?
We have not identified yet, but there is a pool of surgeons that applied even when Bill was applying. So we know the network. It will take us less than a month actually to identify that surgeon.
Great. Now, let's talk about maternal child care, because I know that was an emphasis on the additional kinds of surgeries that will be able to be performed. So how's the experience of a mother undergoing a difficult birth going to change as a result of the work that's going to be enabled by the prize?
At the moment, we are not able to offer obstetric services, which are delivery of any mother, even simple delivery. We've had experiences where women, because we are near the road, by the way, we are near a main road, so the trauma cases of the, but we also have mothers walking through our hospital thinking we are able to provide delivery services. I think, Bill, you can explain the two cases that we experienced a few months ago, where we had women deliver even under a tree within the campus. just give us a bit of that.
Yeah, so this was after I had a long day. I was walking to the car park to leave. It was later in the day, around 6. Then we just noted that there was a car that was rushing into the hospital premises at a very high speed. This car parked right under one of our main trees within the campus, but near the main entrance of the hospital. When we went near, because the driver kept on shouting for us to go and attend to them, when we went near that, we found that there was a lady who was actually in labor, but was on her way to a hospital, which is 10 kilometers from us for delivery, because there's no hospital near us that offers such services. So she knew that we do not provide obstetric care here, but she had no other option. So they just stopped right here. When I went there, that's when I noted that this lady was actually in labor and was almost delivering. And we had no time to take her into the hospital. We ended up conducting the delivery just right in the car. There was myself and one medical officer who was also knocking off. So we ended up doing that just beside that, under the tree in the car. There was also another incident within the hospital premises where the nurses called us that they had received an emergency. When we went to attend to them at the ER, we found that it was a lady who was already in labor and she was ready for delivery. So we ended up conducting the delivery, and at that juncture we learned a lesson because we thought we were not a maternity unit and we do not stock one of the important drugs that we use during delivery, which is oxytocin. And we had to run around the hospital to find out if we have some. So even at the moment, we have a few stocks of oxytocin because now we learned our lesson that people, they think that we provide everything under Partners in Hope roof, but we do not. So we have stocked some drugs that we could use in such kind of emergencies. So we know that this maternity wing is going to change a lot for women who live within our catchment area.
Yeah, I would say from day one, people saying, please start maternity.
Yeah.
But maternity is not something you can do halfway.
Yeah.
You have to be ready to handle obstetrical emergencies as they come up. So you really want to have qualified people, good staff. And then you also, in addition to obstetric care, you need to have neonatal care.
Yeah.
And this has been really an emphasis throughout AMH at many of our hospitals. We helped to sponsor an annual conference on neonatal care that has made a huge difference in hospitals that previously, when babies came early or if they were sick when they were first born or even had some struggle just from a difficult birth, the staff was not ready to handle it. And so we definitely will couple this with training from Steve Swanson, who's in Tanzania, some of our other partners, so that they also have really an excellent neonatal care. So when women come here, they know they're going to get excellent maternal care, they're going to get excellent neonatal care. And I think it will really raise the standard, I think, for the whole district, I think.
And on top of that, half of our population is actually young, under 40. So we know these people will be having babies. It's a reproductive age group population. So this is really one of the unmet needs, not just for the catchment area of Partners in Hope, but we have very few facilities against a large population, where women can safely deliver with all the privacy and confidentiality that's needed. Yeah.
So we have some really good questions in the chat, but first I'll read a comment that was posted in the chat from, I think, someone in Malawi. Dr. Agnes Moses is a visionary, compassionate, and results-driven leader whose work continues to transform healthcare delivery in Malawi. With unwavering faith, integrity, and strategic foresight, she leads a hospital with servanthood leadership, commitment to excellence, and a deep compassion for the most vulnerable. Dr. Moses has strengthened clinical systems, expanded access to quality care, and inspired teams to serve with professionalism and Christ-centered dedication. Malawi is proud of her and her team.
Thank you. Thank you.
So a couple of questions. Interesting one here. If additional human resources are being considered to enhance surgical procedures and their access, how will you sustain the service beyond the depletion of the prize money? So when the prize money is all spent, what remains?
Maybe you want me to talk about the SAFE program?
Yeah.
Or you want to?
I think you can talk about
You can
yourself.
talk.
Well, one of the great things one of the best programs I think AMH has is what we call safe surgery, surgical access for everyone. And we recognize that in a country like Malawi, very few people can afford even the actual cost to deliver surgery, paying the surgeon, keeping the lights on, the equipment that's needed. And so we have actually a great opportunity, especially for our new donors, to come on and sponsor a surgery. And they're
Perry, how
priced
much
out
is that? So if someone wanted to
on the
sponsor
surgery.
one surgery, how much would it be?
Depends on the surgery and the country, but we were talking about a mastectomy costing about $700 for all the care. It includes the surgery and the hospitalization and such. In the US, it's probably $40,000 to $55,000 for someone to have a mastectomy. So, you know, but $700 for a Malawian is a huge amount of money. So we would call this performance-based financing, where rather than just giving them money, we say, well, if you have a patient who can't afford surgery, we sponsor the surgery that pays for the cost of two Partners in Hope, plus a very small profit margin to help with running the rest of the clinic. So it's really our strategy to try and create a low bar for donors to say, hey, I can. In Uganda, it's $200 to have a C-section. In Malawi, it's $700 to do a mastectomy. And so it's a huge, very small amount of money, often from the mindset of US healthcare, but it can literally save people's lives.
Okay, another question in the chat. Given the imperative of maternal child care, why surgery before MCH?
Why surgery?
Why surgery before MCH? Because surgery, we already had foundations for surgery, and the investment that is needed for general surgery is a little bit less than what you need for MCH, because MCH is not just maternal, it's also child health. So we are talking about antenatal care, prenatal care, labor care, postnatal care, not just for the mother, but also for the baby. So in most cases for surgery, like our first theater, there was already space, and it doesn't require a lot of space. MCH requires a lot of space, and it also requires what we call neonatal intensive care unit in case the babies are born with, they need assistance, intensive care assistance post-delivery. So that was our thinking, but it's all in our strategic plan of 2022 to 2026 that we've just concluded. Yeah. So we'll go on. We wanted to build one service after another. Eventually, we are hoping that we'll have all the traditional 4 departmental services of medicine under one roof.
The main reason for waiting is really it requires more physical infrastructure. And so the $500,000 goes a long way, and we actually reserved a bit of money towards this. If we could raise an additional $500,000 to $700,000, we could start both of them at the same time. And that would be fantastic. And I know that would
how much, Perry? So
another smile
if
we could do that.
So Perry, so another 500 to 700,000 would do precisely or approximately what?
Yeah.
Another 500 to 700 would help us establish the MCH on top of the expansion of surgical services that we've talked about.
Yeah, a maternity center would have you'd have some outpatient space, you have delivery suites, an operating theater and ward space, and a neonatal nursery. So that all of that we could get with that amount of money.
So let's talk about numbers of patients who will be helped. So how many more surgeries will be enabled by the current prize, the 500,000, and over what period of time? And Perry, to what you just said, with an additional 500 to 700,000, how many women and babies could you help?
Why don't you go ahead and start?
So I'll go first for the surgical patients.
Good.
With that prize money, we'll be able to assist at least 9,000 patients till the end of the period that will have this prize money. So we expect that every year we'll be able to do 1,800 more surgeries. So that's how far this prize is going to take us into surgical patients.
9,000 surgeries. Wow. Okay, so Perry, if you could just talk about or just expand on what you were just saying about an additional 500,000 or 700,000 dedicated to maternal care. How many women and babies approximately do you think could be helped over some rough period of time?
With the size of a unit that we're talking about, it wouldn't be like a huge hospital unit, but we'd probably look at maybe a capacity of about 200 a month for deliveries. And then, of course, there's a certain percentage of neonates that would need more advanced care, maybe a few percent of those. And so I think it would make a huge impact in the sickest of kids. Ideally, we'd want to have a good pediatrician and a good obstetrician so that high risk pregnancies might even choose to come here because of the level of care that they can get here, similar to what we're seeing now with HIV patients. The sickest HIV patients, they know to come here. We do dialysis here. So we get some of the sicker medical patients because we have an ICU and CCU. So we really want to be seen as a cut above what's available at the government and the other private hospitals in town.
Okay. Okay. Jason Fader. Jason is the first winner of the L'Chaim Prize.
Yeah.
Jason, that would have been 10 or 11 years ago. Great to see you here. I'll just read your comment in real time. Congratulations, Dr. Agnes. One question: as your clinical capacity increases through MCH and laparoscopic surgery, do you have a couple of management principles that will guide you and help increase the system's capacity to make the most out of the new surgeon, for example? Thanks for any advice you can give.
Thank you, but I think thank you for the congratulations. I think I need some clarity on the actual question first. I may answer
some of the operational challenges of expansion.
Yeah, and actually, Jason's question corresponds with another question in the chat, which is, let me just find it and read it out loud because the two questions go together. Dr. Moses and Dr. Maranya, you were doing great stuff in patient care. Great stuff. I am wondering how you are hedging your administrative roles, given your responsibilities with patient care. So what are the guiding management principles that help you both do your surgeries and medical care as well as to run the hospital?
Let me start for myself. As Perry said at the beginning, I'm coming from a research background where I worked as both under people, but also I was heading or leading some research work within Malawi. I was affiliated with the University of North Carolina, but within here in Malawi, they have a research institute. One thing I think that helped me, what I carried over to PIH, was the paying attention to detail, because research protocols require a lot of attention to detail. It's a rigorous process for a protocol to come out and even to operate research. So my real management principles, really, I put passion to whatever I do it with passion. I don't look at what I do as a job. To me, what I do is a passion. It's what makes me tick, if you understand. But another thing, I think within our setting, you have to lead by example. Because yes, I'm in management. I'll give an example during the COVID in 2020, 2021, 2022. Instead of me just sitting down and giving oversight, which I could have done, but if your team sees you being hands-on, they get encouraged and they follow suit. So during the COVID, he was here as well. We were both in the tents looking after patients and so on. So one of my principles is you lead by example. If you want people to have integrity, you have to demonstrate it yourself. And in terms of combining management and clinical service or clinical care, most of the times it's a matter of time management. So what we have both done is to separate time or to assign time to our clinical services for cases that need our expertise. Like I do a clinic on Tuesdays. He has his 2 days of clinic and some days of theater. Then the other days we dedicate to administration. For me, every day, I'm usually on, because I'm an internist, I'm not in theater. So I do ward rounds with the team so that the skills I have, I'm also able to impact others and I can trust them when I'm not around. So in a nutshell, a big nutshell, by the way, it's a huge nutshell. Those are some of my personal management principles. I'll hand it over to my colleague, Bill.
I think Dr. Agnes has preempted almost everything that I wanted to say. But one of the things that I wanted to hint on is that the key that I've seen is in time management. And as he has rightly put, I do rounds as well in the morning. So I do an early ward round. By 9 o'clock, I'm in theater. I operate if there are cases. Sometimes I schedule cases because I know that I have some administrative duties that I need to carry out. So sometimes I may schedule cases between 9 and 3. Then the remaining 2 hours, I may do the administrative work. There's one day that I have purely dedicated to administrative work. But when there's an emergency that comes in, I leave the administrative work and sort out the emergency first. So that's how I've managed myself and managing mainly both the clinical and the administrative role. It all leans on the time management, how you fragment your time. So, but the other thing is, as Dr. Moses has already alluded to, you need to be able to teach the young ones other simple things. You may not leave them with complex issues, but you need to teach them how they can examine and how they can investigate an acute abdomen. So they may give you just a summary at the end of the day that we have this patient who has this. And most of the times you go there just to confirm because your juniors are good enough, you have mentored them well, and they are able to diagnose other things. They may just tell you that this is what's needed. The difference with me and Agnes is that she may just dictate the management over the phone. But for me, if it is something that needs to be done, I need to be hands-on. I need to get into theater. So this is where, Mark, initially I said that the second surgeon is very important in this role as well. He's going to free me a little to carry out more administrative duties. And he will also be able to attend to emergencies properly, himself and myself, on time.
Okay, so
one thing I would add, Mark, I guess kind of like kids, I think of Partners in Hope as my kid. So you can brag on your kids, right? So, when I come visit here, I'm just so proud of the team that they have, and I think there's a couple of things that have contributed that having money from USAID enabled us to really recruit some real top level people at every level. We have our chief operation officer, Ethel, an excellent finance person, and Daniel, I know you're watching, so that's a heads up, and excellent clinicians helping us to manage our HIV programs as well as give care. UCLA has been an amazing partner for us, coming in, doing rotations and training our clinical staff in how to just excellent care, and even the ICU, CCU. So it's not just these two guys laboring. They have just a fantastic team here, administratively, clinically, and in their support staff that enable them to really free them up to do the things that they do very well. So just bragging on the whole team.
No, so deservedly. So many good questions coming in. Okay, a couple questions about your Christian faith. How does your Christian faith motivate you, and how is it reflected and experienced by patients in the hospital?
We'll start with you.
Okay, you want to start?
She's our pastor. No.
Yes, one, my Christian faith, I will start to say if it wasn't for my faith, probably I wasn't going to take up the job at Partners in Hope. Uh, as Perry said, because it meant going down on my earnings by 32% that time. So for me, my job is my God-given assignment. I would put it that way. So I look at patients, or even not just patient, even management. I look at management even as an assignment from God. So in that way, I'm sure if everybody thought of everything they do as their own assignment with passion, then you give out your best, you give the best you can. Do we sometimes make mistakes? Of course, we do. But what matters is if you're giving out yourself in good faith. So that makes me sleep well at night. I think I'll make it that short. That's how my Christian faith plays into my job.
For me, I would say that I believe that healing comes in different forms. And one of the forms of healing is through medicine. And in this way, I would say also through surgery. So as I'm performing my surgeries, as I'm practicing surgery, the art of surgery, I believe that I'm in a ministry that God has given me to help heal people. So I feel that my everyday job that I do is a calling, is a ministry that God has given me. So when I'm performing that, I know that this is a duty that I'm performing as I'm performing unto God. So that's what keeps me going every day. And the satisfaction that I see on patients, the happiness that I see on patients. For example, a patient who comes in with a hernia and it gives them a lot of trouble, but within an hour you help them, you sort out the issue. They're healed in a week or two and they're up and about. Seeing the smile on their face when they're coming to the clinic for review, that gives me joy in itself. So that in itself as well keeps me going. And that gives me with my faith in God.
Well, Bill, that's so beautifully put. I'm just glad this is being recorded so your incredible witness can be captured and shared. So someone note what minute 37. Okay, a question for Agnes. Actually, two questions surrounding the same theme. Given your background and interest in research, do you have time to continue those activities given all of your other responsibilities that we've talked about today?
Thank you for that question. I considered that when I joined Partners in Hope. I'm not actively or hands-on on the research as I used to be, but we have a unit here, a portfolio of implementation research, which is under Partners in Hope, whose findings I'm part of that, though I'm not the frontliner. What is different is where I'm coming from, I was the frontliner. Wow, here my role is more of oversight. But I do have a chance in my time, not just free time, because of my interest. I read a lot of upcoming protocols, both clinical trials or implementation research. And it's also satisfying for me to see the results. For the one who has asked the question, it's for their own interest as well. And that led me to be appointed I'm one of the reviewers of clinical trials. I was one of the reviewers for about 8 years of clinical trials research that is happening in the country. This is from the same background. So though I'm not on front line doing research, but at the back, I was actually able to see the research, the protocols before they come out in the open. So that kept me going. Having said that, I think I'm happy even doing what I am doing without having to be a frontliner.
So more good questions. So here's a very practical one. I see the
Yeah.
poster about the PIH dialysis unit. How active is the unit? Is it for daily use or emergent cases?
So that's also a good question. PIH has a dialysis unit which has 5 beds, and it's usually daily use, both for chronic dialysis patients, even for emergencies. Currently, we are operating from Monday to Saturdays, except Sundays. And we have about 25 patients who are on chronic slots, 25, yeah? 25 dialysis patients who come on chronic basis, on chronic meaning twice or 3 times a week to be dialyzed. And that has also been one of, I would say, flagship transformations at PIH. It's really filled in a huge and practical gap in the nation. Thank you.
Okay, two questions, similar and important. So I'll just read them both together. This is getting back to the previous question. How does your faith get to reach your patients? How intentional is it? And the second related question is, how do you disciple staff at the hospital?
Disciple. How do we disciple? Thank you. Do you want to, because I took over the ministry from Perry. Our hospital, we intentionally have what we call spiritual life ministry. That's to empower staff, to not just empower them for evangelism, but also to encourage them in their faith. So within this ministry, we have a full-time chaplain who is one of our employees, and he's got a team of other Christians, a team of staff members who are within the ministry, but we consider all ourselves a team of that. Within this team, we have specific activities. One of the activities, or one of the operations of the spiritual life ministry, is to move around to go to inpatients. We pray with the patients. Sometimes there are sessions of encouraging patients. We have spiritual counseling. That's how our team works. It's interwoven. It's not about one person, but it's about a team. For the ward visits, it's a daily activity. That happens. We take turns. People take turns. Of course, not necessarily myself taking turns, but within the spiritual ministry. Then for staff, on Wednesdays and Fridays, we are still continuing. We meet as staff every morning, where we share the word of God. We encourage each other. We sing. Some of them are cultural, some songs are cultural, others are international, but that's how we keep encouraged. Sometimes we have prayer retreats and so on. That's to encourage staff, to empower them to be able to impact, share the love of God with the patients. You want to add, maybe?
I would say, in my adding on top of what Agnes has said, is that it's easy to give out something that you have inside you to someone that you're meeting. For example, in my instance, my patients that I see and those that we are going to theater for, you'd be amazed that one of the items on our surgical safety checklist is that we pray before we start our surgery. So, but that, of course, we ask the patient what their faith is, and if they are willing and if they are open, that we could pray with them before we start. So sometimes even just that gesture, sometimes patients have asked me afterwards, maybe when they come in for a review, Dr. Monya, are you a pastor for a particular church? I said, no, I'm not a pastor. So I think in that way, somehow, somewhere, you end up impacting on their lives, on their spiritual lives, in some of those little things that you do with the patients.
A question, or actually, this is a comment in the chat. I'm excited to learn of the expansion of surgery and maternal child care. Congratulations, PAH. Your approach of excellence and empathy intertwined with trust in God gives us hope in life indeed a key partner? Okay, here's another. Let's talk about training. So we had a question just come in about training. So you've given several examples of developing and training staff. How will planned expansion of surgical and maternal child care enable you to expand your ability to teach others? And so let's just talk generally about the role of training that's going to be enabled and amplified by the L'Chaim Prize.
All right. So in terms of surgical capacity, we know that Partners in Hope is in an area where there are umbrella training institutions, for example, College of Surgeons of East, Central, and Southern Africa. And for this, for one to qualify to be a member of that, or for you to be a training center, you need to at least have different specialties of surgery for you to become one. At the moment, I would say that I do not have any resident, but I believe in myself that I'll be able to mentor someone to become a good surgeon. And this prize is going to enable us to have all specialties under one roof. We'll be able to have orthopedics, general surgery, urology, and so we will be able to become a training center for surgery, for example. But on top of that, with the expansion that we have had, as Dr. Agnes was mentioning earlier on, we have an ICU and an HDU, which are critical for surgical patients and maternal patients, because anything can happen in theater, but as well, we may end up reviewing patients who are quite sick. So we have been able, for example, in the past 2-3 years, we have been able to train 4 people in critical care management. We have, at the moment, we have well-trained critical care nurses. We have also a critical care clinical officer. And next week, in fact, we are sending another officer to go and train in critical care. So this expansion of services is also bringing in training in different aspects. But let me also point out here that some other nurses and some other clinical officers and other medical officers on the ground have managed to learn other critical care activities. They have managed to learn dialysis. They've managed to learn other procedures in theater. So this expansion, directly and indirectly, is also enhancing our learning in other cadres of people who are employed here.
Okay, another question from the chat. Thank you for sharing your vision and heart for providing quality, equitable, and sustainable healthcare in Malawi. What are some of the challenges to achieving this in the setting of Malawi, and how will this grant help?
So for Malawi, we already know that the doctor to patient or per population is the lowest in the world. For us at PRH, the main challenges we have in our health system, the first challenge is human resource. The second challenge, I'm picking out the bigger one, is the clinical infrastructure. The only challenge that's not there is the number of people needing care. That's a lot of people needing care. So with this prize, as we said before, one, it will close some gap in terms of human resource. We said we needed a second surgeon. He was being modest to say when he says he's the only full-time surgeon. Apart from that, because sometimes we need to call him from home, even after he's had a hard day, because there's less or fewer skilled people we can call on. He has to be called probably 1 a.m., 2 a.m. to come and help. So this award for PRH will close that gap. Number 2, in terms of the general health system in Malawi, because when we say health system, all the health facilities are part of that health system. So we feed into the whole national health system in Malawi. When we take off a little bit of the burden from the public or the national health system, it means the national health system gets some relief, or we improve the national health system. That's the way we are looking at it, because we feed into that national health system. It also, we've talked about equipment. Medicine is a dynamic field. It's evolving now and again. Now there's laparoscopic surgeries, which not only do they shorten time for the patients, not only do they shorten the operating time or post-operative stay in hospital, but it also cosmetically helps the patient, because we are no longer having to cut the patients, leaving them. We avoid some morbidities, post-op morbidities or comorbidities. So it will help both at patient level, at PIH level, and at national health system level. That's the way we are looking at it. It's not just introspective for PIH.
Yeah, actually, Agnes, I actually just asked ChatGPT about surgeons per population in Malawi, and it says the specialist surgical workforce in Malawi is estimated to be 0.43 surgeons per 100,000 population.
Yeah.
Yeah, and the WHO says there should be 20 per 100,000.
Yeah.
So, God bless you in the work you're doing, because the people you're going to be training and the people they train will amplify that number very significantly in a quite reasonable amount of time. And by contrast, in the U.S., general surgeons alone, that seemingly implies not specialists, general surgeons alone are typically estimated to be about 5 to 7 surgeons per 100,000.
Wow.
Okay, let's see, some more interesting, really good questions from the chat. Yeah, we talked about this at the very beginning, so I'm glad that this was inputted here. How do clinics around the country associated with PIH interact or feed into PIH?
You have to
Yeah.
take that, because
Yeah,
I'll finish.
the HIV, there's a large HIV capacity building program where we are supporting people who are working in the hospital, and we also have people who go and visit and provide supportive supervision. And those are really focused on HIV. And the work outside of Partners in Hope, we have a fairly large HIV clinic here, the free clinic here. But our work outside of our Partners in Hope facility is really going to depend heavily upon how the world decides it wants to support Africa's HIV problem. And HIV, when I first moved here in 2000, 60% of the people I saw were dying from HIV. And now, and actually, when we opened up our inpatient ward, almost the whole ward was filled with people with late stage AIDS. And now it's rarely seen, because people are taking medicine, they're getting on it early, they're staying well, they're living normal lifespans. They're starting to get problems like hypertension and diabetes and all the usual old people diseases. What I'm concerned about with HIV funding is that we will lose some of the progress that we've made, and potentially slip back, and we'll start seeing people dying from AIDS again. And if they are off and on their medicine, you get resistance that develops to the drugs, the first line drugs, and they have to take more expensive and more toxic drugs for second line. And so, whatever, and I know AMH is doing advocacy and many others to try and keep funding going for AIDS programs. The governments are now realizing they also need to step up their support. But we've made so much progress, and there's a threat to losing that progress if we don't keep resources coming and keep attention on the AIDS epidemic.
So I think we'll just do one more question before it closes out, and I'll address it to Perry, because you just referenced that you first got to Malawi in the year 2000, which of course is
Yeah.
more than a quarter
Yeah.
century ago. So just reflect on PIH from that time when it was founded to now and to where you see it in 20 years from now.
Yeah. I mean, it's already gone way beyond the first vision that I felt like the Lord gave me to just care for people with HIV. That was my heart. And I was thinking, hundreds or thousands, not right now, where Partners in Hope is impacting about 200,000 people on treatment. So it's just amazed me. What's also amazed me and came out even this week when I was visiting here is that we don't see sick AIDS patients in the hospital. We see patients with heart failure and pneumonia and just normal kinds of things. And that's just so drastically different from the situation we had when we moved here. And what I really see the future being, not just with this process and this grant, but is Partners in Hope really growing to be a sort of the model medical institution, maybe even growing to be. We'd love to get more land around us and expand our ability here. But I think more excitingly is the standard that you set, and then the capacity building that Partners in Hope can do within the whole system and help sort of set a new standard for what's possible in Malawi. And once people see what they're doing at Partners in Hope, maybe we can do it here. We're having an opportunity to have Agnes come to the States in April, the last couple of weeks of April. And so we will be certainly visiting New York and California, but there'll be more opportunities for us to engage with people. Be in touch with us if that's something you're interested in attending some of our things, especially in California and New York. But we're excited really to try and double or even more than double the amount that Mark and Erica have generously given, and really see this as a new season of growth in the capacity for Partners in Hope. We just appreciate all of you attending today. Mark, I'll let you close too, if you have any closing comments. We're
Sure.
wrapping up.
Well, three things. One, thank you, Bill, Agnes, and Perry thank you is not even the word, but it's the word I got for now. I mean, thank you for all you've done and for all you're doing and for your vision and for your execution. It's been just a blessing to be able to support the sacred work that you're doing. And Agnes, I look forward to meeting you in person at Shabbat dinner at our home in late April, and
Yeah.
Hopefully to meeting you, of course, and hopefully you meeting lots of other people in New York, California, and elsewhere who can get to hear firsthand about the holy work you're doing, and to join us all in partnering to support it. And along those lines, let's see, in the chat at 12:26, if anyone wants to scroll up, there was a post to a link that if anyone wants to bring us closer to our 700,000 goal, that's in addition to the 500,000, which will help to enable the vision that Bill, Agnes, and Perry have articulated. Someone could contribute right now, and the links there was posted at 12:26 and posted again 12:55. So
And
the
you
links
can
are there in the
scan the
chat.
little QR code that's on the screen here, I think, if it's big enough.
Oh, I
Yeah.
see that. Yeah, I didn't see that. Then there's a QR code on the QR code on the screen. Right. I was looking at you. I didn't see the QR code. Yeah.
Yeah. And thank you so much, Mark, for your example of generosity. I mean, it's just it's something that exudes from you and Erica, and we're so appreciative.
Well, thank you. And I'll just close with a comment here in the chat. May God continue blessing PIH.
Thank you. He will.